let's share together some innovative techniques in intrauterine surgery. In this case, the ultrasound shows and prove fundal intramural myoma. I can say it's between type 3 and type 4 because it's not touching the endometrium. It's a little bit more deep embedded into the myometrial of the fundus, and still it's not reaching the serosa. Actually, type 3 is an intramural myoma touching the endometrium. Type 4 is intramural myoma touching the serosa. So there is no something in between in the classification. So let me put this case as a category between type 3 and type 4. So we know the site of the myoma from the pre-operative ultrasound, and guided by that, we go by the scissor. And in this case, I was training my colleagues in a workshop. So I hold the hand of the student and teach him or her how to handle the scissor. So moving the scissor blades and turning 180 degrees or 90 degrees. This was integral part of the training. And then we start to cut into the fundus, knowing in mind that the myoma is a little bit deeper. So we have to go through the myometrium, which is looking very wide. There are so many settings you have to put in mind during this procedure, that the distension of the cavity of the uterus should be enough to separate and stretch the uterine walls and keep tissues under stretch and avoid any bleeding during cutting. Because if the intrauterine pressure is less than the vascular pressure, once you cut into the myometrium, blood will flow inside. And it's not a terrible bleeding, it's not a serious, dangerous bleeding, but it will stain the fluid red, and it will be like the Japanese flag, everything is red. That was my concept long time ago, and it took time till the communities and the authorities and the guidelines and the companies to absorb this, and now all the new machines have a setting different than in the past. So let's go on and keep cutting into the fundal myometrium until we reach the myoma. And now it's obvious for the observer that there is a shadow of a different structure tissues appeared behind the wall or the curtain of the fundus. And the myoma tissues is solid, rounded structure. And it's not like the interlacing fibers of the myometrium. It's very important to distinguish the myoma from the myometrium. Now I take a very quick cuts, and here I'd like to highlight how to use the scissors. When you cut by the blades, you cut and pull back. I mean, don't cut and push in. If you push in, you will violate the tissues and might perforate. As you see, again, please, I invite everyone to look at the movement of the scissors. It will take time until you get used to it. So cut and pull back, and not pull back all the way, okay? Just half the way. And when you pull back, you get a better panoramic view, because when the scissor is pushed in, it occupies a big area or an area from the view. So when I cut and pull back, it is safer, and it gives you a chance to assess what you have done. Now, I'm moving around with the scissor, circular, all around, to free and liberate the myoma. It's about 1.5 centimeter myoma. And I forgot to tell you the indication: the patient has failed IVF trials, repeated implantation failure. Now, I do a nice trick, because there is no grasper that can actually hold this small myoma. I will show a trick how to hold it. The myoma is almost free from all the sides except little part near the fundus. Keep watching and enjoy the procedure. Now this is a very crucial step that I'm going with the telescope into the capsule of the myoma. This fine fibers in the myoma capsule. Here you have to be very close to the tissue. So another golden tip. Pull the scissors back so you see only the terminal part of the jaws. Don't see the whole shaft of the scissor. And push the whole system. Again, pull the scissor back. Just see the blades and push the whole system to go into that space. You are working almost without panoramic view. So we have to be very tactile sensitive and to identify the tissues of the capsule. This is how to liberate the myoma from its attachment as much as possible. There will be still a remaining part not dissected. Let's keep watching and see what to do. Well, and now I come to what I call it a $1 million tip, okay? Because there is no grasper with big jaws to grab the myoma. So use the scissor to stab the myoma, open the jaws to hinge the myoma into the scissors and pull down so you do complete avulsion of the myoma, because those little fibers is still attached superiorly, and by this maneuver you can get it out. My dear friends, I hope you enjoy these tips and tricks and wish you good luck. This is Osama Shawki from Cairo, Egypt.